Hello everyone, welcome to the third part of hemodynamics. Today we will be discussing a very important concept which is nothing else but embolism. Embolism. Last session I have told you that we have thrombus. When this thrombus undergo dislodgement, and they reach faraway sites, the end result is embolism. Define embolism. Pulmonary embolism can be asked as an essay question. It has been once asked in your prof exam as an essay question. I will explain that very soon. So what is embolus? It is a detached intravascular solid liquid or gaseous mass which is carried out by blood from its point of origin to a distant site, and at that distant site it will cause some tissue dysfunction or infarction. I will tell you what do you mean by infarction. Infarction is death of the tissue as a result of ischemia. How ischemia occurs? Due to hypoxia. So the most common cause of cell injury is hypoxia. Most common cause of hypoxia is ischemia. Fine? Yes. We have a wide variety of this. So remember, the most of the cases this emboli are dislodged thrombi. For example, this is a blood vessel. Here some thrombus is formed, and this thrombus will get dislodged. And this thrombus get dislodged. Fine. And this thrombus will get dislodged, and this will finally cause something what we call as embolus. Yes. Fine. So the most common cause of an embolism is nothing else but thrombi. That is why we call this as thromboembolism. We have other different types of embolism, that is fat embolism or nitrogen bubbles. Nitrogen embolism or nitrogen bubbles, you have studied about Benn's disease or Kaysen's disease. That is again a different type of embolism. Of course, we have something called as cholesterol emboli, tumor fragments, bone marrow, or even foreign bodies. Foreign body aspiration, a vegetative matter, or any other food substances, that is called as aspiration pneumonia. That is also a type of embolism. Amniotic fluid embolism, fat embolism. So all these are the different types of embolism that we are encountering. Fine? Yes. Once this is done, let us study about pulmonary embolism. As far as pulmonary embolism is concerned, remember, they will give a case scenario. A 39-year-old male. This 39-year-old male had a fracture of femur. As a result of fracture of the femur, immediately the patient developed dyspnea. That means breathlessness. Then he collapsed. He died. This is the scenario. Whenever, at last finally you will study the whole 2 volumes of Robbins. When they come fracture of femur, you will immediately start thinking about some bone tumors or something. But remember, it is not like that. Bone fracture is one of the predisposing factor for what? Pulmonary embolism. Why? Because fracture of the femur is a highly vascular bone. Femur is a highly vascular bone. So the blood will forms thrombi. The blood will it forms what we call as a clot or thrombus. Okay, it will form clots or thrombus. And what? This clot or thrombus will get dislodged. And remember, from the lower limb, all the veins drain into IVC, into right atrium. Finally, it reaches the lungs, leading to PE or pulmonary embolism, life threatening. The patient will die immediately. So what will be the question? Once this is done, what will be the sub question? Number A, your diagnosis. Answer, pulmonary embolism. The most predominant risk factor for pulmonary embolism is deep vein thrombosis due to prolonged immobilization. There will be deep vein thrombosis. That is the most predominant risk factor. So in your case history, if there is the word mentioning called deep vein thrombosis or prolonged immobilization, okay, I am writing here prolonged immobilization. Okay, prolonged immobilization. Okay, prolonged immobilization. Okay, what will happen? Prolonged immobilization, all this, what will happen? Yes, again it will cause deep vein thrombosis. As I have told, it is one of the most important, okay, risk factor for pulmonary embolism. Okay, fine. So they will give you first diagnosis. That is the sub question. Number 2, the pathogenesis or what is the mechanism. That is the mechanism what I am going to see in pulmonary embolism. Number 3, 2 autopsy findings. See, autopsy. So the patient died. Okay, anyway, remember if there is any bone tumor or anything, the patient won't die immediately. Am I right? Yes. So they will ask you what is the 2 autopsy findings. And D, they will ask you 2 investigations. 2 investigations to confirm your diagnosis. Fine? Yes. So, pulmonary embolism originating from deep vein thrombosis are the most common form of thromboembolic disorder. Remember, I told you DVT is the most important risk factor. So, the fragmented thrombus from the deep vein thrombosis. Why there is a deep vein thrombosis? What do you mean by deep vein thrombosis? You know, in the lower limb, we have superficial veins and deep veins. Superficial veins are the great saphenous vein and short saphenous vein. Whereas we have something called the deep vein, that is the popliteal vein, femoral vein, all this. Whenever any thrombus formation within these veins, what will happen? It will finally reaches the right side of the heart and finally it reaches the pulmonary arterial vasculature. Depending upon the size of this embolus, it may occlude either the main pulmonary artery or sometimes if this occludes the, see, you can see here, this is the pulmonary artery bifurcation. So any thrombus which occludes the pulmonary artery bifurcation is what we call it as saddle thrombus. What is this called as? Saddle thrombus. This is called as saddle thrombus. Okay? Yes. Or sorry, saddle embolus. Not thrombus, it's saddle embolus. This is called as saddle embolus. Okay? Yes. So, and remember, sometimes this embolus may rarely, it may reaches even the systemic arterial circulation. Normally, it won't enter the systemic circulation. Why it doesn't enter the systemic circulation? Because this thrombus is formed in the venous system. So it will reaches the right heart and from there into the pulmonary arterial vasculature. Rarely this thrombus may enters what we call it as the venous system, the arterial system, and such a case when the thrombus from the venous system enters into the arterial system, we call such a condition as paradoxical embolism. It may be asked as an MCQ question. Okay, MCQ question, what is paradoxical embolism? That means the thrombus which initially originate in the what we call it as the venous system is paradoxically, okay, that is rarely it is going to what we call it as into the arterial circulation. In which case it will enter? Remember, in the case of interarterial or interventricular, in case of ventricular septal defects, okay, interventricular septal defects, what will happen? This thrombus which is originating in the venous system will reach as the arterial system. Fine. And remember, most of the pulmonary embolies are clinically silent. Fine. Yes, see, the patient may have sudden cardiac death and cor pulmonale. Okay, fine. And they may also cause pulmonary hemorrhage. Okay, fine. And the embolic obstruction of small end arteriolar pulmonary branches often produce hemorrhage, and okay, they may also cause pulmonary hypertension and right ventricular hemorrhage. So I remember as the pulmonary embolism is concerned, you should know these features. How the patient will present. The patient will present with the what? Right-sided heart failure. Very, very important. Right-sided heart failure. We call it as cor pulmonale. Okay, we call it as cor pulmonale. Fine. Yes. And remember this what features, that is dyspnea. There will be any fracture or any trauma, or there may be prolonged immobilization. Okay, they will ask this question. Then 2 autopsy findings. What are the 2 autopsy findings you are going to write? Yes, what are the 2 autopsy findings you are going to write? I am going to write here the 2 autopsy findings. Number 1, you will have a thrombus. You are going to write about what? The structure of the thrombus. And number 2, yes, is emboli. Number 2 is emboli. So the first finding is thrombus in histopathological examination, and number 2 is emboli. Remember in histopathological examination, thrombus and embolism cannot be differentiated. Both are almost morphologically similar, because the thrombus and emboli, we use the word to differentiate both terms. They differ in such a way that emboli is nothing else but a dyslogic thrombus. So when they ask you about the autopsy findings, you have to just mention about the thrombus. And 2, investigation to confirm the diagnosis. Of course, you can do a chest X-ray. Then you can also do a CT. Okay, chest CT. Okay, chest X-ray, CT chest. Then another one more thing, you can go for PFT, pulmonary function test. Okay, this has been a question which has been asked very rarely. If my memory is right, some 10 to 12 years back, they have asked this clinical case scenario question. After that, they have not repeated this question, but still remember, okay, they may ask you pulmonary embolism. Okay, yes. Next, I told you what is paradoxical emboli. Fine, yes. Next, I am going to tell what is fat embolism. Remember, fat embolism refers to the presence of microscopic fat globules. This also occurs as a result of fracture of long bones or in the setting of soft tissue trauma and burns. See, remember, the pulmonary embolism also occurs as a result of what? Fracture of bones. And at the same time, fat embolism is also most commonly associated with the fracture of long bones. Okay, yes. So, fracture of long bones is most predominantly associated with what? Fat embolism. Okay, most common association with. Okay, associated. But you will ask me, then sir, in such a case, what I have to write? Whether I have to write whether it is a pulmonary embolism or whether I have to write about fat embolism. In such a case, I will tell depending upon the clinical case scenario. Okay, depending upon the clinical case scenario. For example, in pulmonary embolism, the characteristic features of right heart failure, that is what? Dyspnea, okay, sudden death, all these occurs. In fat embolism, remember, in fat embolism, there will be pulmonary insufficiency, and the death, it doesn't occur suddenly. Whereas in case of pulmonary embolism, the patient will immediately collapse. Okay, I will discuss about fat embolism. So whenever there is a fracture of long bones, because of the microscopic fat globules which will enter the circulation, the fat embolism sets in. Okay, yes. Remember, most of the patient will be asymptomatic. Okay, most of the patient will be asymptomatic. Okay, and we use a term called fat embolism syndrome. That is a term applied to a very minor group of patients who become symptomatic. Most of the patients are asymptomatic in case of fat embolism. Okay, yes. And remember, this I told only very few patients will be symptomatic. This is the reason why I told you that in such a case, whenever they give a history of any fracture of long bones, you have to go for the answer pulmonary embolism, because fat embolism, it is very rare. And at the same time, the patients they will very few patients only present with the typical symptoms. What are the symptoms? Pulmonary insufficiency, then thrombocytopenia, anemia, and neurological symptoms. Okay, and remember, it will take minimum 1 to 3 days for the characteristic symptoms. What is that? Tachypnea, dyspnea, or progress to delirium or coma. So, suppose in case scenario, dyspnea develops after 1 to 3 days with history of long bones fracture, you can write fat embolism. Fat embolism is a short knot question. Fat embolism is a short knot question. Okay, fat embolism is a short knot question. Fine. And why there is a thrombocytopenia? Remember, it is because of the adhesion of the platelets to the flat globules, and finally all these platelets will be consumed in the spleen. So that is the reason. Similarly, there will be red cell aggregation, petechial rashes, all those things. Fine. Yes. Remember, very few will present in these classical symptoms. See, you can see here, you can see a bone marrow embolus in the pulmonary circulation. Bone marrow embolus. Whenever you see this picture, don't confuse it. Okay. This typical fat globules will be seen only in case of fat embolism. Okay. Yes, you can see the cleared vacuoles which represent the marrow fat. And the relatively uniform red area. See, you can see here, these are the fat globules, and what region you are seeing here. I am drawing with blue color. This is nothing else but an organized thrombus. This is nothing else but organized thrombus. Okay, that is also present. Organized thrombus is also present. Remember, it is made up of fibrin. Okay, yes. Okay, so I told you there will be red cell platelet aggregation, which will occlude the pulmonary and cerebral microvasculature. So the patient will have CNS manifestation also. Okay, the patient will. That is why I told you, what is that? Irritability, delirium, coma. All this because of this small microthrombus. Okay, it is a microemboli. Unlike the what we call it as the pulmonary vein, pulmonary embolism, or in case of deep vein thrombosis, here it is a very microemboli. So it will mainly occlude the very small vessels, that is cerebral microvasculature, everything, and the fat globules may release the free fatty acid, which is responsible for toxic injury to that of the endothelium, and it will also cause platelet activation, free radical, further damage. Okay, all those things. Fine. Yes. And how will you demonstrate this? Of course, in normal hematoxylin eosin state, you can see the fat as clear vacuoles, whereas we have some specialized staining. What is that? Frozen section, as well as stains for fat. What are the stains for fat? Oil red O, Sudan, black B. Fine. Yes. Okay. Once this is done, let us see about air embolism. Fine. Okay. In air embolism, let us see, the gas bubbles will obstruct the vascular flow, which causes ischemic injury. So whenever there is a communication between our circulation and the outside air, fine, what will happen? We have a negative pressure gradient which will suck the air. Am I right? And air may be introduced into the cerebral circulation in the sitting posture, creating a gravitational gradient. When the surgery is done in sitting patient, or when we accidentally puncture any vein, due to negative pressure, the air will be sucked in. And remember, in order to produce a clinical effect, or in order to produce a significant air embolism, minimum 100 ml of air is important. Okay, and this microemboli will get finally trapped in the pulmonary capillaries, which will further induce some inflammatory response, and even when these bubbles enters the central nervous system, the patient may go for sudden onset coma. An important short note question for you, already asked in the year 2020 for my batch. They have asked this: decompression sickness. When the individuals experience a sudden decrease in atmospheric pressure, decompression sickness, also called Caisson's disease or Ben's disease. Scuba divers, deep sea divers, all they are at risk. Fine. So normally, when they dive deep first, there will be high pressure. So more amount of gas will be dissolved. And when the diver depressurizes or ascends rapidly, these bubbles or the nitrogen will comes out of the solution in the tissues and the blood. And these nitrogen, so since he is ascending rapidly, so that is why we usually advise what? You should ascend slowly to prevent this Caisson's disease. And this rapid formation of these gas bubbles, this will enter the skeletal muscles, joints, and finally it will be causing a painful condition called as bent. Why it is called bent? Because of the characteristic pose, that is the Grecian bent. Okay, that bends because of the severe pain. In lungs, this was the question they have asked: what are the pathological findings in Ben's disease? In lungs, the gas bubbles will be present in the vasculature. First, you have to write about Benz disease, Caisson's disease. Then you have to write that in lungs, they will cause what? Atelectasis, collapse of the alveoli, emphysema, and they may finally cause a respiratory distress syndrome called as CHOCS. Respiratory distress syndrome called as CHOCS. Okay, so this is what we call as Benz disease. If this disease is present over a chronic period of time, for example, Caisson's disease. That means for bridge construction, some people have to work under very high pressure. Am I right? So during when they come back to the normal ground atmospheric pressure, what will happen? There will be this problem. That is, the nitrogen bubbles will come out and it will cause a severe pain. So that is the chronic condition. We call it as Caisson's disease. But usually, as per physiology textbook, this Benz disease or Caisson's disease, that both terms are used interchangeably. What will happen here? There will be presence of gas embolism in the skeletal system, multiple focus of ischemic necrosis, more commonly on the head of the femur, humerus and tibia. Fine? Yes. So what we have to do in order to prevent this, we have to allow slow decompression, or we have to ask the divers to ascend slowly. Fine? This is about what we call it as the Benz disease. Next. Okay. Next, amniotic fluid embolism. This is not that much commonly asked, but still for image-based MCQ question, what happens in amniotic fluid embolism? Remember, it is the 5th most common cause of maternal mortality. As a result of, this is one of the most important complication in immediate postpartum period. The onset is characterized by sudden severe dyspnea, cyanosis and shock, followed by neurological impairment, which ranges from headache to seizures and coma, and as well as disseminated intravascular coagulation. So what will happen? The amniotic fluid, which is normally present along the embryo or the fetus, it will rupture, am I right, during the time of delivery. Sometimes this may reach through the uterine vessels, it may reach the maternal circulation. The mother may present with severe dyspnea, cyanosis, shock, neurological impairment. This is actually what we call it as amniotic fluid embolism. Remember, this amniotic fluid embolism is mainly because of activation of some pathways. I mentioned about DIC. Why this DIC occurs? Because it is told that this amniotic fluid has some vasoactive substances that is responsible for acute pulmonary hypertension, right heart failure, left heart failure, pulmonary edema, and diffuse alveolar damage. Okay, unlike the other embolism, that is what we call it as a pulmonary embolism or the fat embolism, here the pathogenesis is mainly because of the vasoactive substances. In AF, that is amniotic fluid. Vasoactive substances in amniotic fluid. All this is responsible for, okay, yes. So what will happen? The classical findings at autopsy include presence of squamous cells shed from the fetal skin, lanugo hair, fat from vernix caseoso, mucin derived from the fetal respiratory or gastrointestinal tract. All we can see in the maternal pulmonary circulation. Fine. So you can see here, what you are seeing here is the what? Fetal squamous cells. What you are seeing is the fetal squamous cells. Okay. So far, we have discussed about what is embolism. We have discussed about pulmonary embolism, fat embolism, air embolism, amniotic fluid embolism. Out of that, pulmonary fluid embolism is very, very important. Now let us see what is infarction. Okay? Yes. Infarct is nothing else but an area of ischemic necrosis caused by occlusion of either arterial supply or venous drainage. Fine? Yes. Most common type of infarction we encounter are pulmonary infarction, bowel infarction, or any ischemic necrosis of gangrene, diabetic foot gangrene. All this, they are also type of infarction. Infarction means, remember, mainly it refers to coagulative necrosis. Coagulative necrosis. Arterial thrombosis or arterial embolism is the most common embolism rather than the venous. Fine? Okay. Yes. Now let us see. I told you the infarcts may be due to either arterial cause or venous cause. Now, according to the color and presence or absence of an infection, we have two types of infarct. One is called red infarct. Red means venous. White means arterial. Remember these 2 points. How to remember? Red. Why venous? Venous blood is deoxygenated blood. Deoxygenated blood. Blood stasis. So you will get red color. Artery. There is no venous stasis. Am I right? So it is white. Remember like this. Red infarct occurs with venous occlusions. Example, testicular torsion. Remember, red infarct occurs in tissues with dual circulations. Dual circulations. What are the areas you know having dual circulation? Number 1, lungs, small intestine. Am I right? Yes. So those regions which are having dual blood supply. Dual blood supply. That is most commonly lung, small intestine, of course testicular torsion. We have red infarct. Fine? Yes. Because of sluggish venous outflow. Whereas white infarct occurs with arterial occlusion, I told you. They occurs in organs with end arteries. End arteries. What are end arteries? No anastomosis. Heart, spleen, kidney. So, whenever you heard the word red infarct, remember lung, testis, small intestine, dual blood supply, venous drainage, occlusion. White infarct, end artery supply, that is heart, spleen and kidney. Arterial occlusions. Arterial occlusions. Fine. Remember, the infarcts will be usually a wedge-shaped infarct. See, you can see a wedge-shaped infarct. See, this is a wedge-shaped infarct. Am I right? Wedge-shaped infarct. This is a red infarct. It occurs in the lungs. Whereas what is this? This is spleen. Spleen, you can see white infarct. White infarct. Fine. Why this occurs like a wedge shape? Remember, in this wedge shape, the occluded vessel will be at the apex and the periphery of the organ will be forming the base. Suppose this is a wedge shape. In the apex we have occluded vessel and the base is formed by the organ. Periphery of the organ. Periphery of the organ. Fine? Yes. Okay. And you know the extravasated red cells will be phagocytosed by the macrophages. Heme iron will be converted into hemosiderin. Hemosiderin. Okay, fine. This is responsible for the brownish discoloration. Remember the histological characteristic feature I have already told you. Infarct means what? Coagulative necrosis. Coagulative necrosis. Exception, brain. In brain, infarction is infarction is liquefactive necrosis. Liquefactive necrosis. Fine? Yes. Okay. What are the factors that influence development of an infarct? Anatomy of the vascular supply. I told you, end arteries we will have what? White infarct. Whereas dual circulation due to venous occlusion drainage in lung intestine will have red infarct. Another important thing. Am I right? Liver has both hepatic artery and portal vein circulation. They are relatively resistant to infarction. Suppose if they ask you question, out of red infarct and white infarct, which is more common? White, most common. Red, rarely. Why? Because there is dual blood circulation. Chance of infarct is very less. Chance of vessel occlusion is very less. Chance of tissue damage is very less. Remember, that is one of the causes. Anatomy of the vascular supply. So the availability of an alternative blood supply is the most important determinant of whether the vessel occlusion should cause a tissue damage or not. I told you the liver, which has dual hepatic artery and portal venous circulation. Similarly, hand and forearm has dual radial and ulnar artery. Whereas the renal or splenic circulation, they are end artery. So sudden, a small occlusion may cause tissue damage. That is the first reason. Second reason, rate of occlusion. Slowly developing occlusions are less likely to cause infarction. For example, here this is a blood vessel. When the occlusion occurs slowly like this and finally complete occlusion, this is a slow occlusion. Infarction chance decreases. Why? Because collaterals develops during this time. Whereas a fast infarct, what will happen? No chance of collaterals. Okay. Best example, coronary arteries disease. Sudden occlusion of coronary arteries. Sudden occlusion of coronary arteries. We are not giving the time for the collaterals to develop. That is why myocardial infarction is very common. Tissue vulnerability to hypoxia. Neurons undergo irreversible damage when deprived of their blood supply for just 3 to 4 minutes. This is an MCQ areas. Neurons withstand hypoxia for 3 to 4 minutes. Fine. Myocardium can withstand hypoxia for maximum of 30 minutes, but tissue death occurs only between 4 to 12 hours. Tissue death. Most resistant to hypoxia is fibroblast. This is a very, very important MCQ question. Very, very important MCQ question. Very, very important MCQ question. Okay? Yes. Finally, hypoxemia. That means because of low blood oxygen. Hypoxia and hypoxemia. What is the difference? Hypoxia means decreased oxygen to tissue. Hypoxemia means decreased oxygen in blood. Very basic question. They may ask in any clinical postings. Fine. Hypoxia and hypoxemia. This finishes infarction. So today we have discussed different types of embolism and different types of infarction. I hope the session is useful for you. Thank you. Fine? Yes.